Okay, welcome everyone to today's program. Welcome. I feel a bit nostalgic because something that started about 6, 7, 8 weeks ago is coming to an end, and I don't want it to end. But like every good thing that starts well, ends well, and we're really very, very happy for the opportunity of sharing with you, learning from you of how to do this. And today I look forward to sharing breaking news with us because I know it reassures us we're in the right path. And so thanks again for joining us. Let me quickly share my slide. And I want to thank Reverend Johan for coming back to be ready for us for the various questions we have for him as we work on these final stages of the whole person health course. And whether you intend to implement a course in a community or in an institution, the important thing is you will take home a message, not just for people out there, but starting from you. How can you integrate whole person health into your health agenda? If you didn't have an health agenda, please do one after this. So thank you. So today is also the end of the course, a wrap-up session for us. And we really appreciate your input, your feedback, your evaluation to help us design a more robust program for the next session. So today is going to be a short session. I mean, we'll keep us within 1 hour. I'm currently doing the introduction now. We'll look at the final course overview, and then interactive session. It will be governed by you. It will be dictated by you. And Reverend Johan has been kind enough to be here today to answer our questions. And other faculty members are also here. If there are other questions from other sessions, please feel free to put them in the chat room and we take them at the end. Finally, please evaluate the course for us and we'll appreciate everyone. So as I reflected back on this course, I just knew that we went from Whole Person Health course 501, where we learned about the foundations of whole person health. And that built on the issue of culture and healing and various traditions that are basic to us, to our beliefs, to how we should see whole person health practiced. And then we delved into phytomedicine and how it's integrated within the health system. And how can we bring it forward? How can we integrate it in the current medical practice today? Of course, connecting mind, body, and spirit. These three things cannot be dissociated from each other because anywhere the body goes, the mind is there with it. But I'm happy that there was interconnectivity amongst all the sessions. And then lifestyle medicine and integrative health just laid it out for us as to what we can do to be more proactive and intentional in our health. Of course, we looked at the current tools, AI tools, systems tools that could help us really run with this. So we are very happy, and we are also grateful for those students, those participants who put thought into this, captured everything, and are working on their projects. So it's really been a very great learning course for us. And as recap of the course objective, our main aim as we see it evolve had been to promote the integration of whole person health. Wherever you are, as an individual, as an organization, as a community, as an institution. And then we understand the basics, the biological, social formulation of it, the social determinants of health that makes health comprehensive. We've also been equipped with research methodologies, learning from experiences from other organizations and experts to tell us this is the way to go. And of course, advancing it with technology. The course had also not just having esteemed global experts. We really curated them from all over the world. And I'm so proud and I'm so happy that they were not just willing to come, but to share their expertise with us. So that was great. We've done a pre and post evaluation. We've shared experiences, personal experiences, and then we've been having interactive question and answer session, which we are going to be concluding today. And those who also submitted their final projects. I tell you, as we reviewed, as the faculty reviewed this, it was really great to see the thoughts that have been put into this. So thank you so much for everyone that did that. We'll be issuing certificates to eligible people, especially those who were able to attend some sessions with us. So we want your full name. We don't want to send certificate to iPhone or an abbreviation. So please rename yourself as needed. You have questions, please post it there. We'll look at it as we go along. And then thank you for joining us today again. Thank you for joining the last session with us. And today, the wrap-up session, we are honored that Reverend is here with us. So sit tight. All your final questions, please send them out and we'll be happy to address those. Okay. I like the way he was designed, the session was designed, so don't worry about this. Okay. So on the final project, I'm not going into details in this. We know what it is. We know what you can write on the basis of either care, advocacy, research, or education. And you know what to include in that, your audience in integrating social determinants of health. We have also given specifications. If you want to write below 5 pages or above 10 pages, just work with your supervisor. That can be, worked out. And then we have also provided information in case you have questions, feel free to send those to us. But what I want to conclude as we get to our interactive question and answer session is this thing that really has been building momentum. And I'm just saying recap. In our course 501, we talked about the foundations of whole person health. We looked at the science and we looked at the trend it has gone over the years. We look at the faith issues. We look at the NIH Whole Person Health Index and how we are integrating them and all that is the science behind it. So that was February 14. I'm still recapping. And we advocated for a paradigm shift, intentional shift, shift from treating illness to cultivating health, prevention, upstream. We looked at integrated care, not just fragmented care. Somebody in charge of your head, another person in charge of your arms. No, you are a whole person. So we should have whole treatment for us. And then we view people not as patients, but acknowledging them, respecting them, honoring them as a whole person that has a life, that has a family, a place to stay, or place to work, food and shelter, a living being. And we thought that all this is grounded on science, is grounded on spiritual wisdom, and we should run with it if it's to be equitable. And we are still recapping. We also said, which area do you want to focus more? Is it emotional, spiritual, financial, your health-seeking behavior? So we threw back the challenge to you to go home and do something about your health, the health of your family, the health of your association and organization. And in conclusion, of all that we had said, we said whole person health is doable, and it is the future of healthcare delivery, and the future is here. So with that in mind, that was, February 14, and we are here on April 4th. Breaking news. And what's the breaking news? The US government has announced a $100 million grant for a 3-year cooperative agreement. What is it talking about? Making America healthy again. And what are they doing? Enhancing lifestyle and evaluating value-based approaches through evidence, Elevate model. And as we look into the details, they want something progressive, evidence-based, focused on whole person care approaches. Lifestyle medicine, I think they were listening to us when we were presenting our course. Lifestyle medicine, not currently offered by the original medical care we know as it is now. It has to be cost effective. They want to quantify it. And we know how treatment is more expensive. So I don't know what else will convince us that we are on the right path. And this is the right time to run with this. And I believe even as the American government is promoting this in their health system, it's going to go global. Other countries and other regions will adapt it to suit their context. And I think if you don't want to be involved, this is the time to get involved so that this impact, this funding, this opportunity will not pass us by. We'll be able to make a change wherever we are. We are decision makers. We are policy makers. We contribute to a lot of things in our localities. So let's go make whole person health a reality. Okay. As we go along, we'll post the evaluation course again. Please just share with us your experience. All right, and then we'll take this again at the end. And like you see, at the beginning, we've been thanking you for joining us. In the middle, we are thanking you. At this end, we are still be thanking you. And for participating, you're so wonderful. Our presenters are just stellar. And all the subjects, the topics we gave to them, they did a very good homework and it tied to their area of expertise. We are grateful. And for our faculty that have been meeting weeks after week, months after months, to make sure that this is a reality, we thank you. And for our audiovisual team, to make sure that we see you when you are talking and so on. Everybody has made a lot of input into this. For all the sponsoring and participating institutions, we cannot name all of them. We really want to thank Global Oncology University, for hosting us, for convening this, the Global Health Catalyst Summit, for making this a reality. And I know last September when we talked about it, had a forum on it, discussed a lot of things, and then we are now having a product we can share with the rest of the world. I think is truly commendable. And for all those that work behind the scene, coordinating social media, audiovisual posting, and inviting friends to come and join, we are truly very, very grateful. So we'll talk more about this. So thank you. Without further ado, I just want us to relax, send your questions in, and we'll take them. Thank you. Stop sharing. Okay. Feel free to open up, ask, raise your hand. We ask you either AI raising of hand or physically raising of hand, whichever, if you want any comment or anything to add to this. Thanks for listening.
Thank you, Dr. Gloria. If I can jump in here just to so this is kind of a moment of improvisation. So I wonder whether any of those who are present would care to just tell us if they're working on a project, what the overall theme is, the direction that you are working on. I think it might be good to hear some of what people are thinking and working around, especially in light of that the final slide that you shared for regarding the ways in which the administration is committing itself to this work of whole person health. So it's urgent work, it's ethical work, but it is also the work of entire sort of communities now, including policymakers, administrations. And so there is a huge future to this field of whole person health. Um, so I just wonder if any of those who are present who have projects, of course you are not obliged to do that, but I just thought it might be good to hear people talk about a little bit about their projects if they care to. Yeah, Dr. Saida, will you coordinate this time? I'm sorry, I jumped in, but
No, you can go ahead, Kenneth.
Oscar, go
Yeah,
ahead.
Yeah.
I can hear. Um, yeah, I am here, but let me see if there is any question.
Yeah, I think
Um,
Oscar had his hand up, so you go ahead, Oscar.
yeah.
All right. Thank you, Dr. Kenneth, and thank you, Dr. Gloria and team for putting this course together. It has really been very enriching and impactful, especially with the various lecturers who presented during this period. I think it's an interesting course because it does not really focus on science. It doesn't focus on arts. It's a combination of both, which is really interesting because somebody like me who is neither science nor art has actually benefited so much on being part of this course. Uh, Actually, I'm trying to work on a project on how to improve the care of patients in the PCC health sector. PCC, which is Presbyterian Church in Cameroon. Being somebody who is from Cameroon and who has worked in the system for some time before traveling to the US, I have a little bit of background knowledge on how care has been happening in that system. And from the very first lecture where we talked about upstream and downstream, it actually stuck in my mind. When you look at upstream care, it's really something that we need to see how we can implement it in our various communities because upstream care looks at the person, not the illness. What are some of the hindrances when somebody needs to come to the hospital? What are the challenges that person face? And when that person is sitting in front of you, are you looking at that person as an economic tool, or are you looking at that person as a person who has a challenge, and what are these things that have hindered this person not to be able to do what you are expecting that person to do? So I think those are some of the things that I noticed while I was working in the PCC, that most of the healthcare practitioners lack some of these things that the upstream system teaches us to utilize, to be able to understand that when a person comes late for an appointment, or when a person is not able to come for an appointment, there's some existing factors that are hindering that person, and how can we try to see how we can eliminate these factors to be able to make sure that that person has the ability, when he or she is sick, to be able to come to the hospital on time, is able to provide to get the medication that he or she needs to treat themselves. So that's the area where I'm trying to see how I can use the upstream system to educate, especially the frontline people. The receptionist, when a patient comes to the hospital, the first impression is how does the receptionist receive that person. It paints a different picture on what that person is expecting in the back office when he or she meets with the doctor. So those are some of the things I want to try to see I can look at and see how we can improve on the health of the health sector in PCC. Thank you.
Thank
Yeah.
you. Thank you. That was great.
Uh, the Oscar was what was the Oscar's point is correct. Like some of the hospitals actually train their receptionists to be friendlier and coordinate well. So this is something, should be part of the healthcare training. Okay, so there is a question from Will, that what are some simple ways we can start using whole person's health without it feeling like too much? Yeah, that's a very like what are the low hanging fruits we can grab? Yeah. So who do you think Gloria may have some thought about it?
I think let me try to give some thought about
Yeah,
what
sure.
Dr.
Go
Wu
ahead,
just
Oscar.
So I think the low-hanging fruit that we need to use for people not to be overwhelmed with whole person health is the educational part of it. When we educate the community to understand how to take care of themselves, that is one very important aspect. Like Dr. Reverend Johan said in their work in Nigeria, using the people on the ground to make the decision on what you want to use to impact their lives is very important, because when the people on the ground are the central focus of shaping your ideas on what you want to do, not you bringing your ideas and imposing on them that this is how I want things to go, makes a big difference and makes people to know that they are valued, they are seen as an important instrument in your decision making or in your area of improvement or encouragement, or in your area of bringing something to them that they do not have, because they might have the knowledge, but they don't know how to express it. But when you put them together and you discuss with them and you make them to understand that if we do things like this, and they give a lot of input into what you want to do, you'll be able to shape it in such a way that it will actually improve their health, their lifestyles, and their health, especially with the kitchen stove that Reverend Johan introduced. Standing and sitting. You saw that most of the women said, "Oh, sitting is good because they can be doing one or two other things." But if they decided to, and they can say, "Okay, no, you'll be standing," because in the West we stand because we have counters where we can walk on. But when they made that decision, that it will be good for them to sit down and walk, that changed a lot of things, and that made them feel important, that the idea that we gave to our partner was utilized for our good. So I think that one of the most important thing is education, educating our communities, educating the people that we want to support them. Thank you.
Yeah, thank you, Oscar. One comment from Susanna. I think she said, thanks for organizing the interesting course on WPH. I like that word, like the jargon of WPH with the whole person health. Thanks, Susanna. And another upstream care from Gloria. Upstream care at all level is critical to integrated whole person's health programs. Yeah, that's true. Do you want to explain a little more, Gloria?
Okay. Yes. I was just supporting Oscar's concept. And I totally agree with the issue of education. And upstream care will not leave anybody behind. Sorry, I always have some stories to share. I spent about 4 or 5 years in the Gambia doing reproductive health as a research gynecologist. And because of the culture and context, you need approval of various levels. The women will agree, the chief will agree, but when it comes to doing investigations, you need the approval of the household. And here we are in our team. I had about 3 or 4 women work with me. The only male person was a driver. So they've already consented on this day that we needed to take them for ultrasonography in those days, because it wasn't in the local hospital I was working. The the woman, were getting ready for them, and we didn't see the woman come to the place we needed to be. So we visited them to pick them. And I sent the locals, we're all African. I sent the local ladies. They went into the household, talked for close to 15 minutes. The woman didn't come out. And I said, okay, they call foreigners too bad. So I went in. I talked, all I could. This is safe and everything. Another 10 minutes, no show. And do you know who went and brought out that woman in 3 minutes? The driver. Our driver, he knew the system. He understood everything. He got engaged in everything we're doing. This driver said, okay, let me go as a man. He went in. Within 3 minutes, this woman came out. Assuming the driver did not know what we're doing, following up with Oscar's comment, assuming the gate person doesn't know, the receptionist doesn't know, it's only the doctor and the nurses that knows about whole person health, it will succeed. But if everybody gets engaged and play their part wherever level they are, policy level, funding level, program level, customer service, it should be integrated and ingrained in everybody. It's not like the doctors feeling this shouldn't be so. And I think sometimes another thing in following up with what Oscar said is put yourself in a patient's shoes. How would you want to be treated? And draw a map of how that should be. Respectful care. It shouldn't just be when women are delivering. Healthcare is customer service. You may deny me a service, but you are smiling. And I'm happy to accept that denial. But if you are denying me a service and you are abusing me on top of it because you saw me enter your healthcare facility, then that is not acceptable. And when we bring in social determinants of health to help us understand the context with which people are working, then it makes a lot of sense. Some people would rather want to die in their huts than go and meet that healthcare or be in that system where they disrespect them, abuse them, and don't want to assist them. So that paradigm shift, that preventive upstream care is what we should promote, and it's feasible at all levels. And then we escalate it. And when the preventive measures don't work, then we go to the complementary side, which is the treatment side. But by then we have exhausted all other alternatives to wellness, to wholeness, before we get there. So I think that's it. The other thing I want to add, how we can make it not overwhelming, is just taking it little by little. If the overwhelming problem is sleep, let's tackle that sleep first and then resolve it. We celebrate baby steps. If it is issues of weight or poor nutrition, we take one bite at a time. And by the time we realize we have a plan over 6 months, we are achieving what we want to. But if we're having a program and then, okay, you must make sure you sleep these hours, exercise, do this, it could be overwhelming, plus your normal life schedule as a human being. So let's understand people's context, where they are, and just work with them at the speed they want over a long time. And I think having those will be critical. And then we shouldn't forget the decision makers, the funders, the people who call the shots. They should be part of whole person health. The chief medical officer or the director of a health institution should be part of it, so that when the systems begin to change, or they can facilitate in terms of policies and funding to make the whole person health a reality. So, and whole person health, the preventive side cannot stand alone. It has to be complemented by treatment and care, which is what is already in existence. We're just saying, let there be a balance. It's not everybody who wants to eat apple standing up. Some people want to eat apple chopped and maybe apple sauce instead of biting it with their teeth. So let's package healthcare. Let's use policymakers and decision makers and funders to package healthcare in the way that the people will take it. and keep on coming for it, just like my fruits paradigm. Thank you. Those are the few things I think it could make it less overwhelming, both for the individual and the system. Thank you.
Yeah, thank you, Gloria. I think next question from Will for Reverend Kirsch. From your experience with Mission 21, what's one whole person health approach that made a big difference for patients? Also, you also always tie things to development. Do you think whole person health is more need in high income countries or in low income countries? Yeah, that's a good context. Do you think?
Okay, thank you, Professor Will, for your question. I'm not sure I understand your first question exactly well. So let me start with the second one, and then maybe you can give me some highlight on the first one so I don't miss your point. But the second one, do you think that whole person health is more needed in high or in low income countries? Well, if I make reference to my lecture last week and that triangle of needs that I depicted there, that was a very typical Western, in your words, you would call it the high income concept of whole person health, you could say so. And in my view and in my experience, they are both needed the same. And but the problem is that maybe in high income countries where the top part of that triangle of needs is often regarded by the, for example, by the practitioners, they regard that as unprofessional or individual and personal thing that I don't want to touch. So if you have any illness and I don't touch that upper part of the triangle, but I just go until the middle, until your health or so, but you don't go further. So as long as you find it unprofessional as a medical professional from high income countries, you find it unprofessional to take into account the religious, cultural dimension of the person you are trying to help, then you have the bigger challenge than those medical professionals in low income countries. For them, it's much more obvious that it's part of your whole person health. So in other words, I think whole person health, although it's patient-centered, it actually, the concept starts with you. It starts with your own mindset, the way you look at the patient, the way you look at yourself, your own role. And it's not about your values. It's not about your mindset. It's not about your concept of health, but it's about the concept of health of the person you want to support. And I mean, I still remember the question about how do you include culture and religion also in research in a professional way, quote unquote. That it is unprofessional not to include it in your research because it's part of the whole person. And as long as you find it a challenge or you're doubting your professionalism once you try to do a 360-degree approach, then you have the higher challenge on high income countries than in low income countries. For any doctor from Cameroon, it's obvious that culture and religion are part of your health. And also to refer also to Madame Anima Shaun, I think I still remember your question. It's not about my religion, my culture, or whatever. It's about the culture, the religious convictions of the person you're trying to help. That is key. That sets the standard. Not my own values or religion is important, but the values of the person I'm trying to support. And that, I think that shift, that paradigm shift, is not only a systematic shift, but it's also a paradigm shift that has to start in our own minds and in the view we have on the world and the people we try to support.
And
Yeah, and maybe you can help me with the first question. And I hope I got the second question right, Will.
yeah, so I believe he texted, thanks so much for
Oh,
the first question. Here is more clear, hopefully, version of what I meant to ask.
okay, yes. Okay, now I get it. Yes, thank you. Well, let me go back to the time when HIV and AIDS were really a huge challenge. Now they're becoming one again. But when it's really started, the beginning of this century, we there was we were just about to create access to antiretroviral drugs, but there was a huge resistance to deal with the whole issue because for example, from certain religious circles around the world, HIV and AIDS were depicted as a punishment from God for immoral behavior. And our experience was that it was not so much a moral punishment, but it was more like an immune deficiency of society, because it hit those that were most vulnerable in that society, that had the least right of how do you say that in English? Right over their own sexuality, their own sexual lives, like girls, young women, prostitutes. Those were the ones that had the high infection rates, and I don't think that those girls were necessarily immoral, but what was immoral is what they were not able to protect themselves against sexual violence from others. And so we started I'm trying to cut this a bit short, but our approach was, in the whole of Africa, we got together with all our partner organizations, partner churches in Africa, and we developed actually a joint approach to dealing with people living with HIV and AIDS. And we came up with an intervention where we started with the theological education, trying to make pastors, but also lay people in the churches, understand that it was not supposed to be considered a punishment from God, but it was rather a challenge. And the churches developed T-shirts. Jesus loves people with HIV and AIDS, and we had church leaders going for testing and putting it on the media. Say, I know my status. So to make sure we break that silence and we break the stigma around HIV and AIDS, and also making it a challenge for the communities that they they help people to get access to antiretroviral drugs, but also to include them in income generation activities, in giving them proper health care, also giving them access to the right food that they needed to enhance the immune system, etc. So it was really a community-based approach that encompassed the churches, other NGOs, the healthcare delivery, the government. Everybody was involved, building a role system around people living with HIV and AIDS, and they were in the center with their needs and the way they looked at the world. To me, that made a real difference. And one single approach, just giving out antiretrovirals or anything would not, or putting up a testing station like that without context would not have done anything. But that package that we created through the access of the churches and the trust that churches had with the people, that gave people really the access to that healthcare and to their own owning their own bodies, owning their own whole person health again, not being an object again of a disease or an infection, but being owners. And everybody around them supported them and carried them, and in their Christian faith made them one body, part of the one body of Christ. And that is a very, very strong statement
Yeah.
for Christians. And that also radiated out into the Muslim communities. So they equally took it upon themselves and said, yes, what those Christians are doing makes sense also in our own faith. So they also took it on. It made a big difference, I think, through many parts of sub-Saharan Africa, wherever we were working.
Thank you. Thank you so much for sharing your experience. So there is a question from Modosla. Integrating WPC with local content is vital. We do this when we screen for cancer at our clinic. I have a cancer care clinic in Nigeria and want to work with Dr. Gloria and the health kiosks for cancer screening in rural Nigeria. Um, Gloria, do you have any comment on this? Maybe we can go to the next question and see what she can join.
Yeah,
Okay.
I'll just say that thanks Mojisola for that question. It's really important. I just want to say that this group here, we should not just take it as business as usual. We want to establish connections. We want to establish partnerships. We want to learn from each other. And what I like about the Global Health Catalyst that hosts this oncology university is to empower people, empower partners, bring a coalition to be able to address some of the things you are doing. And thanks for letting me know, because I'm also working with the global this platform to see how we can translate some of this cancer care into the care for people in Nigeria. The comprehensive cancer care in the cloud, C4, is encapsulating all this so that we're able to address that. So please, I'll send you my contacts and let's continue to discuss, because when it comes to, when we will ask me, or when the funders will ask me, who are you working with in Nigeria? I say, yes, I've got somebody. So let's collaborate, let's share ideas, let's share opportunities. And I just believe that this could, foster into other things. And for cancer, we're also working with for the use of the health kiosks that really complements bringing healthcare closer to where people are. It's something we're also working with the Global Health Catalyst to see how can we roll it out to people. How can we make it a commonplace, like some of the data have showed? We don't need to wait for long appointments to reach care. We can reach care anywhere we are. And that's the paradigm shift we need. We want to disrupt the way healthcare is done. It shouldn't just be the doctors and nurses that hold all the key to health. No, we do. Sorry, I'm a doctor, but I have moved from from the downstream side. I'm now more in the upstream side to make sure that things downstream work well. So we're looking for partners, we're looking for collaborations, and as opportunity comes, we want to work with you anywhere you are in the globe. So thank you, Mojisola. We'll be in touch. Yeah.
Yeah, so another question from Yoni. Whole person health is healthcare customized to the individual and their unique situations. Thank you, Dr. Gloria. Okay, let's see if Another question from Mojola. How can okay, so the question is how can Craig's like our key into the WPH program using our facilities in research program and educating one small community at a time. So yeah, maybe Gloria, do you want to go for it, or anybody have any idea on that?
Yes. I think within public health, we should work with one community at a time. I believe in the combining top-bottom approach, also bottom-up approach. And that's because if we just focus on the top-bottom, it takes several years for it to trickle down to the bottom where the need is really. However, if we focus on the bottom up, there is a chance that within a shorter time, they both can meet. Both are complementary. But if you want to see fast result, sustainable result that stays when governments come and go with the bottom up, because they will be empowered to be their advocate, and whoever is in government, whoever calls the shot, they will mobilize themselves to get what they need. So both are complementary. And I just want to share what a community is doing. There's one community we call the program is Umana program. 20 years ago, 2006, a group of people in that community said, oh, we need a health center. So they went with the chief, the people agreed, and they converted the community health center, the community hall. They gave parts to the health center, and the rest, the village still uses it. And then the program went in for about 2 years. I mean, we built it, equipped it, brought nurses and doctors, and to come and rotate care. And within 2 years, we saw things run down, in the sense that the place was vandalized, the lab equipments were gone, the nurses and doctors were not safe, and things cooled down. 3 years ago, we tried a different approach. We now came, okay, Owana is light. And for people of faith, it depended on that. The people that dwell in darkness have seen a great light. So they ran with it. Now, we did it differently. We didn't just bring healthcare to them. We went and did a baseline assessment, worked with the chief, worked with everybody, and then brought in missionaries and development facilitators. So based on what they wanted is what we are now implementing. The chief is bought in, the youth group are there, the women's group are there, and we just thought, okay, let's go preach the word, make disciples of all nations, feed the hungry. They needed more. They needed a market for the women to sell. They needed a school, primary school for their people. They needed roads. They needed lights. Now they've started early childhood education, for those children that roam about not doing anything, teaching them the word, teaching them how to read and write. That is sustainable, one community at a time, working to improve their health. So if we want to really make a change in this whole person health, start with your family. Then go to your community, talk about this, and they will find a way to keep it sustainable. I also present my work. I go to health fair, work in residential homes, do vital signs and check for them at the community level. I mean, residential homes where we have senior citizens, some are younger, some are older. And in this community, what I noticed was, the healthcare we come, they take their vital signs and they get it recorded. I think they had a staff, just like we all have staff, workplace change. So after talking about whole person health, their nutrition, sleep, and everything, physical exercise, they changed everything. By the time I went there in March for the first exposure, and I went there in May, they changed everything. What did they do? They had a printout of their blood pressure, whatever it was. They now said, hey, we've not been exercising as a staff in this place. So they mobilize themselves. During lunch, they take a walk. They used to order for food from some vendors they didn't know. They decided to be ordering healthy snacks, healthy food for themselves. And then when I went the second time, they said they are now focusing on healthy snacks. So they mandated anybody coming to do anything in there, they must have healthy snacks. I didn't preach about that, but as a team, they saw what they needed to change, and they brought that change. And to me, that's what matters most. I also shared the usher that changed his habit and his weight is going down. So until that light bulb lights up within us, in our community, in our circle of influence, we will not go far. But when the light lights here, lights there, before you realize, we will be asking, what's happening? And then they can come and support what you're doing. So educating community, if you want to go far, bring the community. But if you want to go fast and alone, go alone. Your money won't go too far. But if you engage the community, the individual beneficiaries, it will be sustainable. And we are building on something that is sustainable. We want people to detect what healthcare they need. And all we do as professionals, as funders, is support their health initiative. It may be water, it may be other things, but health is health. Thank you.
Yeah, thank you, Gloria. Let me see. Yeah, thanks from Will and Majula for their answers, and I do not see any more questions. So yeah, maybe Kenny, do you have anything to add with Gloria?
I think Will is still here. I don't have any other question, but just to ask, please, if you are Ari, I know I've been taking your attendance, but we cannot give certificate to Ari. Please, could you rename yourself? For others, I think they've corrected, and that's wonderful. Will and Kenneth, over to us now. Thank you. Dear, I didn't know how time flies.
Okay, I have a question from Oscar. This is for Dr. Kenneth. Please, can you elaborate more on your topic during the course, especially the picture you shared of the lady in South Africa?
Oh, right. So that was the picture of Hector Peterson. Hector Peterson was a 13-year-old boy who was shot dead. And so during the demonstration, a young man saw the body and picked him up. And so that iconic picture is the one where he carried the boy, he's rushing to the hospital. Unfortunately, when they got to the hospital, Peterson was pronounced dead. But the picture became iconic because it represented the kind of ethical commitment to the well-being of people. And so part of what the picture illustrated was that, from a whole person health perspective, as we think about the social determinants of health and the communal commitment to this initiative, as everybody has been saying, the only way that this is sustainable is if it is rooted in community and in culture, and there is a shared sense of communal commitment to it. So for me, it was important for us to think about those determinants that impact people's decisions access health or not? What if someone doesn't have the capacity to go? Can you provide a ride? Can you take them to the hospital if they cannot afford it? So there's a certain sense in which, we have to both literally and proverbially carry people to this to this experience with all the important caveats that we have identified, which is that it has to be something that is culturally relevant, something that is owned and advocated for by the local community itself, and people understand that it is not a colonial approach where we come in and tell them this is what you have to do, and then try to supervise them do that, as opposed to this is the ideas that we want to share and learn. So that is what the image was sort of represented, and I connected it to, for those of us who are within a particular faith tradition, a parable that is very important for us. Someone that found another person on the road and intervened. So you move from the emergency intervention, you move the person to the inn, which is a kind of institutional communal space where health is possible beyond the individual person. So as you think about your work, I imagine you started out, Oscar, mentioning that it is interdisciplinary. So, and the fact that it has relevance for you is important. And I think each of us, we bring special skills to this work. And so hopefully you find your own voice, even in your own field of specialization, how this impacts the lives of people across multiple sectors.
Yeah. Thank you.
So how do we know? So after this, so by today or the next day or two, you will all, those who are working on projects, you will all get emails connecting you with particular sort of faculty who will be conversation partners with you. As we have insisted again and again, this is a decolonial approach to education. So whoever is connected with you as quote unquote the faculty person is not going to be lecturing or telling you what to do. They are a conversation partner. They are not there to basically sort of lecture you all the way. So you will get an email that will connect you with two conversation partners, and then you can go from there. So communications will pick up from there with your individual conversation partners.
Yeah. Another question is from Dr. Reverend Krish. Any question from those that are planning for WPH projects? Yeah.
Yes, so Oscar is one of them. So any other questions? Yes.
Nobody.
I know a few. I know a few of them are here. Like we said, it's voluntary, so we just thought others could learn from your experience. But if not, that's still okay with us. Thanks again.
Okay, so so how do you see, how do I see integrating this into the whole the Global Health Catalyst Summit at Harvard? Great question. One of the things that we are hoping to do here is that as you develop your projects, and begin to think about moving into implementation, we have opportunities during the Global Health Catalyst Summit at Harvard to perhaps hear you share on your project, how you are designing it, who are the conversation partners that you've identified that can work with you to implement your project once it moves from design to implementation. And the lecture that Reverend Kirsch provided, hopefully it's given you sort of tools to think about sort of the shift from design to implementation, or even as he invited us to think about from project to program, right? So thinking about 1, 2 layers down the road, the opportunities will be there at the Global Health Catalyst if you are so inclined to share how your project has developed. And we will have opportunities at the Global Health Catalyst for conversations with partners, and to demonstrate the ways in which your work can actually grow. So it's not a we're hoping that this is not something that ends at the level of a paper, but something that moves into the community through implementation.
So if someone wants to implement this whole person health, get encouraged from these lectures, how do they approach? Like, what is the starting point? That's my, my question.
Yeah, let me just take a stab at this. There's nobody who wants to buy a car. Just wakes up one morning, go to the car dealer, pick a car and go home. No, we plan for it. We know our budget. We know what model we need. We just want that same process. What this project design is helping you is think through, write it down clearly so that you can present it for funding. You can present and begin to implement. If you don't write it down clearly so that people can understand your concept, it will be difficult for others to walk along with you. So this is the design thinking phase. And for some people, it can easily translate into implementation. Like if you have a community that's already working and you have your constituency or people of influence or your local church or local school or wherever, you can say, okay, this is the course I attended. This is what I want to do. How can we do it? You share. It may mean training, it may mean whatever, and together, even without much funding, just human resources, you are able to follow through with it and you get real results. So is think about it first, write it down, get input from others. That's why your faculty is here to support you. And then it can enlighten you. Oh, did you remember this or think about this? At the end, it's your project that you are translating into a program, and you never know where that will go. Like this Gloria now, when I shifted gear onto whole person health in the vision of Health Kiosks for All about 4 or 5 years ago, I just said, I'm good on the clinical side. I have traveled and seen still the lack of participation of communities in decision making concerning there. How can I go upstream? Now understanding social determinants of health. And I worked on some things and it's be profitable. Then I got connected with the Global Health Catalyst and we shared idea and then we worked together. And here we are on a course. And even before completing our course, there's a funding opportunity. What else is left for us to fit in ourselves and run with it? And what is happening now will replicate. So this is like we are the first beneficiaries, I would say, of the whole person health concept. Let's do it. Let's go work on it. And thinking through, mapping out what you do, so that if somebody says, oh, I like that idea, come and do it. That's not the time to think. This is the time to think and plan for it. Thank you.
Great.
Yeah.
Thanks, Gloria.
So there is Mojisola mentioned that is interested. Can you be specific? Interested in what? Mojisola, can you hear me?
You can unmute yourself and tell us specific areas. Following her question.
Good morning, everybody.
Morning.
Sorry, I think it's easier. I
Yes.
can speak a little bit faster than I can type. So yes, I found out I have a clinic where, like I said, where we treat cancer patients and we do a lot of screening. So when all the things that we have been talking about are things that we are doing in our clinic to a smaller extent, but that we would want to be able to expatiate on. We've always done holistic care with our patients, but we want to be able to make it something that goes further than even our own immediate community, through education, through training. So these are the projects or program that I think that we would be able to work with the WPPH and integrate our program into something that is bigger than us, so that we can grow what we have with the help of education of our staff, or funding of our programs or projects. So that's what I am interested in, and that's why I'm so excited about this, because it's almost like it can absorb it can absorb a lot of small community programs and make it into something that's more than within that community. I hope you understand what I'm saying.
Yes, yes, thank you. Well, excited to hear that. We're excited to hear that. I mean, that you are interested to move this forward, to build on the work that you are already doing. And again, so hopefully what one of the things that can come out of this is that as you think about this work, again, there will be an opportunity during the Global Health Catalyst to actually share. And perhaps one of the things that you can do is spotlight your clinic as a space where this work is being done, and share some of the work that you're doing, and the plans you have for the next many years. So that would be an opportunity that I hope that you can share with the larger community around the work that you're doing at the clinic.
Okay, thank you.
Yeah, thanks. Does anybody have any comment or?
Yeah. No, I just
Thanks, Sunny.
wanted to two things. One is to thank Dr. Gloria, Professor Kenneth, Dr. Zaider, and the indispensable Ayush, who have really done a fantastic job in putting together this pilot whole person health course. I mean, this is historic. I remember when we started the conversation at the Global Health Summit in Johns Hopkins, when the director of NIH, Dr. Langevin, came there, and how Jochen presented his talk on the monkey and the fish, this analogy, and how this has really now taken a higher level status, now that it's becoming like a, centerpiece of global health. And then, like Dr. Gloria mentioned, also this new funding opportunity, even from the government, really recognizing this. And this really recognizes the crisis that we're facing in terms of mental health, and, tying this whole thing, treating somebody with that, both physical, mental and spiritual care. So, just wanted to thank you guys so much for putting together the course as a pilot, and I think this now is ready for scaling. And I think all the partners, all the people who have expressed interest, is really a good opportunity where, for the next course, we will be able to now scale beyond, like think about want to grow the impact so more people can benefit from this, not just a pilot cohort like this. And then also just recognizing in terms of the collaboration, with Healthcare Kiosk, with Dr. Gloria, and Mission 21, and Oscar's talking about the presidential in Cameroon, who he's already working to set up even an MOU to help, really bring whole person health to all the clinics there. And then also churches in the United States, a lot of faith-based organizations in the United States now that really also interested in this. And then obviously Dr. Saida has also brought the dimension of even talking to um, other faith-based entities as well. So I think this is really a tremendous opportunity for us to build on this going forward. And so one of the things that we would like to do in the next is really kind of structure how we can move this, like Kenneth said, from just pilot to implementation as well, and really who are the partners that we want to go forward. So obviously, we have Mission 21 and Healthcare Kiosk as one of the key people that will help us with this, powered by the technology. So that's really the big component. You remember my own lecture was around the AI and how we can use digital technologies today to extend that. And I also want to acknowledge Dr. Susanna, Professor Susanna, who has really been one of the, I think, the best student, I would say. The best has
And
been.
Oscar, best attendance, perfect
Yes,
attendance,
that
and
is
on
true.
time, always on time.
Yeah.
Yes, I think they deserve an
Yeah,
applause.
yeah.
Yeah.
I think I
More
got
than-
another comment from a student, Nadia. I greatly enjoyed this course and look forward to applying what I have learned in my project.
Mhm.
Okay.
Cool.
Yeah.
Yeah, and I
Thank
see
you.
many other good people. Cynthia, I see you. I know you've been also very loyal, joining every day. A number of other people, Dr. Yemi, all the people who have been there from the start, I mean, even on this last day where we're just having a conversation, you still join. So we become like a family. And I think that going forward, we really just want to, build on that. And I'll also highlight that Dr. Steven, who gave the talk, but is not able to join today, he's gotten some funding to kind of look at how you can build. He's working on funding to look at training on whole person health, like just building capacity between US and lower mid income countries where they can have co-mentored relationships and joint projects together. So there's a number of key things that we'd like to communicate with you guys as we come out of this course today and then build up to the Global Health Summit. So that by the time we get to the GHC Summit in Boston, that we'll be able to not only can it actually just talk only about the design of the project, but like start talking about how you've been implementing some of this in your communities. So thank you guys.
Yeah. Thank you.
Yeah. All right, Kenneth, over to
Okay,
you.
so that brings us to the close of this chapter. But as Dr. Gloria mentioned, and as everybody has emphasized, this is the journey we are on. We just started. And so let's stay connected in the various ways that are possible for us. And a couple of things. One is we really do need the feedback from everybody. If you can provide us with the feedback as we think about, how to improve what works, how to, correct where there were errors. So that feedback is really, really useful for us. And stay connected to the Global Health Catalyst. If you are not connected to the Global Health Catalyst, send us an email. Let us know. We can add you to the list so that you are aware of things that are coming up. Dr. Gloria mentioned that there is this funding opportunity from the government. We have, as part of the team, we have made a decision to send in our application. So we will need to build out from here, and we really want everybody to stay connected, so that we can have the kind of network that is compelling, to move this from concept to design to implementation, in a way that is sustainable. So thank you once again for being a part of this pilot. Thank you for sharing your time and your knowledge and expertise, and especially your commitment to whole person health in the various communities around the world. And I hope that we all feel excited that we are on this journey, and we'll stay on it. We'll stay on it because it is vitally important. Thank you all.
Thank you.
Thank you.
And
Thanks,
then,
everyone. Yeah,
yeah, thank you.
appreciate
And
you.
Nana shared his email address, and then Gloria also share the link.
Yeah, the link for the evaluation.
So if anybody interested, you can. So yeah, final words from Gloria.
And thanks to all our faculty, not just that they presented, but they stayed in sessions. We really appreciate all your commitment. So thank you. Yes.
All right.
We'll keep the chat room for another 5 minutes so that people can complete the evaluation. If that's okay. Thank you.
Dr. Gloria, let's connect maybe tomorrow or Monday.
Sure.
Yeah. All
That'll
right.
be great. Yes.
Thanks.
Thank you
Bye.
so much. Yeah.
See
Goodbye, everyone. Thank you very much
Goodbye,
for having
sir.
me on this
Bye,
Bye.
course.
Reverend.
Really enjoyed it.
Vacation.
Enjoy the
Bye.
weekend.
Yes,
Yeah.
hope to see you all in Boston.
Oh, yeah.
Yes.
Yeah.
Happy Easter
Thank
to
you.
all in advance.
Yes.
Yes.